Thank you, everybody. My name is Bill Morano. I'm a surgical oncology fellow at Loma Linda Health in Southern California. And actually from the abstract, we have an update. We're now presenting a retrospective analysis of 10 years of adrenalectomies and a doctrine of the robotic technique. We found an additional 3 years back through our EMR. So thank you for the opportunity to present this work. I have nothing to disclose. So laparoscopic adrenalectomy has been considered the gold standard for this procedure, the first cases being published in 1992. The first robotic data was published in the early 2000s, which showed some benefits that we all are very familiar with, including improved visualization, improved dexterity and ergonomics. However, it came at the cost of loss of tactile feedback, as well as an increased cost to the patient. There's only been one randomized controlled trial published to date in 2004 with 20 cases, 10 of which were robotic, which showed a significantly increased robotic operating time. However, 4 of these cases had to be converted to traditional laparoscopy. Since then, there's been a number of retrospective and observational data that's kind of showed the non-inferiority of the robotic approach and a learning curve of about 20 cases for this procedure. So with this in mind, we looked through all of our data with the idea of evaluating the patient-related and clinical pathological features associated with the approach to adrenalectomy. To do this, we performed a retrospective chart review from 2010 to 2020 and included patients of all ages, including pediatrics. Patients were only excluded if their adrenalectomy was performed as an en-bloc procedure for a non-adrenal pathology. Since 2010, 80% of the adrenalectomies at our institution have been performed by one endocrine-trained surgeon. From 2010 to 2013, laparoscopy was the typical approach. And as you can see here, these are the port configurations we've used for right and left adrenalectomies in the lateral decubitus position. After 2013, when the robotic platform became more available at our institution, we adopted this approach for pretty much all patients unless there was a clear contraindication to a minimally invasive technique. And again, as you can see here is the port configuration now using the Da Vinci Xi platform. So in all, there were 171 adrenalectomies performed over this 10-year period. After review, 23 of these cases were excluded as they were performed en bloc, typically for a locally invasive renal cell carcinoma. That left us with 148 patients, 125 of which were adults and 23 pediatric. The most common pathology was a functional adenoma in 24% of patients. The median size of all of these lesions was 4 centimeters. As you can see here, marked in red, about 34% of the patients were able to be discharged on post-op day 1, which is similar to the number of patients requiring IV narcotic usage post-operatively. 50% of patients were started on a regular diet. Of note, there were 22 post-operative complications identified in the chart review. However, 18 of these were Clavien-Dindo grade 1 and 2. And of the 11 readmissions within 30 days, 6 of these were in pediatric patients with planned readmission for further oncologic treatment. In the pediatric cohort, there were 15 minimally invasive adrenalectomies, 4 of which were robotic. The median age in the robotic group was 16, and so these trended towards being older patients. In these cases, there was really no significant difference in the size of the lesion, the estimated blood loss, the length of the surgery, the length of stay, or the ability to be discharged post-operatively on post-op day 1. In the adult population, again, there were no significant differences in the demographics of these patients, including the primary pathology. There were also no differences in the median size, length of stay, the need for postoperative narcotics, and the ability to be discharged on postoperative day 1. However, what we did find in our group was that in the robotic cases, there was an association with a reduced estimated blood loss and a reduced duration of the surgery in robotic procedures. So in conclusion, the robotic approach does appear to be safe in select pediatric patients. Just of note, we did our first robotic pediatric adrenalectomy in 2015, so it is very sparingly used for select patients. The robotic and laparoscopic approaches had similar postoperative hospitalization course as well as complication rates. But in our institution, there was an association with the robotic approach with a reduced post-operative time as well as estimated blood loss, and we speculate that this may be representative of both the surgeon and staff learning curve associated with this procedure. Thank you very much.